Good morning. My name is SAIRA SAYEED. I'm one of the vascular radiology consultants from Hull Royal Infirmary. Thank you very much for the invite to talk about vascular intervention this morning. Before I start my talk, I'm just going to briefly talk about what interventional radiology is. So interventional radiology is a subspecialty of radiology where highly technical procedures are done with image guidance. This image guidance could be X-ray fluoroscopy, it could be ultrasound guided, it could be CT guided. Now these interventional radiology is further divided into either vascular interventions or non-vascular intervention. And as the name suggests, vascular interventions are anything to do with the vessels inside the body. Anything other than vessels is non-vascular interventions. Now, a couple of my colleagues are going to talk about non-vascular interventions later this afternoon. So my main focus is to talk about vascular interventions today. So what is vascular intervention? We have heard about surgical procedures, major surgery, where the surgeons open up and do open procedures. We have heard about keyhole surgeries. Some people like to call us pinhole surgeons because what we do is we make a very small hole to access any artery of the body. Well, mostly common femoral in the groins and the brachial artery or the radial arteries. We get into it and then we do our imaging or treat patients. The beauty of vascular intervention is, yes, we have diagnostic imaging, but we can use these catheter angiograms to diagnose or to plan for the treatment. And we also can treat different pathologies as well. Most of these procedures are done with local anesthesia. Obviously, more complex procedures will require general anesthetics. And again, the aim is to do most of the cases as day cases, meaning the patient arrives in the morning, but they have already been pre-assessed either over the phone or they come beforehand to be pre-assessed and they have their bloods taken. So we make sure that, you know, all their medications, we're aware what their medications they're on, and their past medical history, their comorbidities, if they're on any blood thinning medications which needs to be stopped, that's already taken care of. And we also arrange for their blood tests to make sure that their bloods are suitable. So they have the procedure done, and after 3 or 4 hours spending in the day case, make sure that they're okay, they could go home after that. Now, briefly about the history of vascular intervention, obviously would be incomplete to talk about vascular intervention and not talk about the father of interventional radiology, who was Charles Dotter, who discovered plain balloon angioplasty of SFA stenosis in 1964. In the lower left corner, you can see Mr. Dotter injecting contrast into the patients, and he also discovered, before he discovered angioplasty, of how to take quick x-rays in succession, like 2 x-rays per second, which is the basis of fluoroscopy nowadays. So this patient on the right side was an 82-year-old patient who refused to have an amputation, and she had gangrenous and critical limb ischemia of her left foot. On the top images, you can see that there's stenosis in the SFA, which he treated with balloon angioplasty to increase the flow to the blood vessel to the foot, and this resulted in improvement of the patient's ganglion. Obviously, the patient had the foot, the toes removed, but there was good healing of the wound. Now, this is how a typical interventional radiology suite looks like, with a table and a C-arm, which takes x-rays, a screen, a foot pedal, a radiographer in the room. Nowadays, most theaters, especially in most of the tertiary hospitals where very complex procedures happen, most of these theaters are hybrid theaters. Now, what are hybrid theaters? Hybrid theaters have got facilities for both open surgical operations as well as endovascular. So it is very good because you can obtain intra and post-operative images. And they have anesthetic facilities as well for the anesthetic team and anesthetic equipment if the procedure is being done with general anesthetic. There's also positive pressure in the rooms for infection control and air change cycling abilities, which changes the air every 20 seconds. So they're very useful for very complex cases, especially for cases like obstetric emergencies where there is placental attachment abnormalities or trauma cases as well. So moving forward, how do we obtain access into an artery or a vein? So it is Seldinger technique, usually ultrasound guided, preferably, because ultrasound can tell you where the clean part of the artery is, so that you can puncture. If you get into a diseased part, then the bleeding control afterwards is a bit difficult. So as you can see, you obtain access with needle, you get spurting of blood, you insert a wire through the needle comes out, you press on the groin, and then a sheath, which is goes on top of the wire to gain access into the artery. Now the sheath has got a dilator which comes out, and it's got a one-way valve, so you can put catheters and wires through that valve, but nothing, obviously the blood doesn't come out. You have a side port for flushing or injecting. And then we have different types of catheters and of different shapes, which help us getting into all sorts of different, anatomies and difficult arteries. And you can use microcatheters, which would go inside as a coaxial technique in these catheters to help us get to, really difficult, small tortuous arteries. Now, I'm just going to briefly talk about different vascular conditions. The most common that we come across is the peripheral vascular disease. So as in this diagram, you can see that we've gained access from the right groin. We've left the sheath in. You can see a catheter over the top. There's a stenosis on the opposite side, external iliac. This is a basic principle is, if there's a stenosis or blockage that we're treating, we put a wire across it, we put the balloon over the wire, and we inflate. Obviously, balloons come out, they don't stay behind. If the artery looks good, you leave it at that. Otherwise, you end up putting stents in. Now the balloons come in different sizes, and they have different pressures at which they are of different sizes. They have nominal pressure, and they have burst pressure that we shouldn't exceed. Then we have different types of stents. Briefly, there are bare metal stents, which basically you unsheath them inside the artery, and they expand themselves as they come in contact with blood, and they expand to their normal size. Then you have balloon mounted stents, which they don't expand, but you have to inflate the balloon because they're mounted on that balloon, and when you deflate the balloon comes out and the stent is left behind. Usually balloon mounted stents are put in cases where you require precision of positioning, but they're a bit rigid, so they're not very flexible, so they shouldn't be put on joints. The third picture is of stent graft, which are covered stents, so they have PTFE grafts on them, so they usually put in to treat aneurysms, or if the artery is leaking, to seal the hole in the artery. Now, case 1 is a 66-year-old male with a 4-day history of cold legs, progressive weakness, and pins and needles. Now, there are no pedal pulses, and the CRT is prolonged. He's got a past medical history of type 2 diabetes, hypertension, MI. So because he had progressive weakness and pins and needles, he had an MRI scan to look for cord compression. There was no cord compression, so he was referred to vascular radiology and had an urgent CT angiogram of the lower limb. Now you can see on the images on both sides, sorry, I couldn't get the whole video of it. You can see that there's no contrast flowing into the distal aorta, so that's completely blocked. On the second image, you can see that there's some contrast filling the external iliacs and the common iliacs via collaterals. So there's some chronic, if there are collaterals, it means there's some chronic aspect to it. But because there's a 4-day history, it's an acute on chronic, so things have suddenly gone worse. So we brought him in, we did it as a combined procedure in the hybrid theatre in the presence of the vascular surgeons, who opened up both groins because we were going to do over-the-wire balloon embolectomy, and we had to retrieve all the thrombus through the groin, so we had to open up. And when we did some pictures, this is how the aorta looks like. So you have the renal arteries coming out and SMA coming out at the top, and there's shelving of the aorta, after which there is occlusion of the aorta with only small amount of contrast going into the common iliacs. So In the image seen here, we are using over-the-wires Fogarty balloons. So they're inflated on top of the thrombus, and then they are dragged down over the wire with fluoroscopy guidance, and it brings down all the clot with it. On the right side, this was a surgical embolectomy, basically. It's not done over the wire. It's basically done blindly, but because we were in the theater, we had imaging. We did that with image guidance as well. We did this multiple times and eventually got this picture in which you can see that there's still a lot of thrombus and a lot of, the aorta doesn't look very happy. And obviously at the bifurcation as well, there is some clot. So what we did, we put a stent in the aorta to plaster all the clot on the walls, and so that the aorta looks nice. Otherwise, if we had left it like this, the problem would have happened again. And then we sorted out the common iliacs as well. We put some kissing stents in and inflated them with balloons, and that was the end result. So beautiful end result, and the patient's absolutely fine. Second case is an 83-year-old female, previous left below-knee amputation. Now came in with right limb CLI, which is critical limb ischemia, and tissue loss. There was no popliteal pulse, no DPPT pulses. Previous attempt at the SFA and popliteal angioplasty on the right side, but that made no difference. Because we had some inflow images, inflow means the blood supply to the right leg between the belly button and the groin, we just went antegrade, which is we went the right common femoral down, and we did some pictures. As you can see, the SFA looks nice, mild disease. On the second image, the SFA, the adductor canal, and you can see proximal popliteal, so no major stenosis there. The third image is, if you can imagine the knee joint in the middle of that picture, so this popliteal artery, just at the trifurcation into the crural vessels, there's some calcified disease of the popliteal artery with some disease of the TP trunk as well as the AT. And then lower down, some disease of the BT. Going down into the leg, there is an incomplete arch, foot arch. As you can see, BT doesn't supply the foot, it just blocks at just below, just at the level of the calcaneum. So what did we do in these procedures? Obviously, because the calcification is right at the trifurcation, we have to put safety wires down TP trunk as well as AT, because while pushing the wire through, you may raise a flap or a dissection, and if you angioplasty that flap may completely block the TP trunk and you can be in trouble. So we put a safety wire in both, and then as you can see, we've angioplastied the AT first and then the TPT trunk, and we got some good result. That was followed by angioplasty of the proximal PT. And coming down to the foot, because this patient previously had some attempt at angioplasty with not very good results, we decided to treat the arch. So we attempted going from the PT posteriorly, but it was completely blocked. So we came round from the AT, sorry, my arrow doesn't work, but we came round and we crossed the blockage and we ballooned all the different segments of the artery. Sorry. And this was the end result. So good result. We've got the arch going, and the patient has done really well and has not gone for an amputation so far. So that's another good result. Now, the other very common things that we do come across is the dialysis access. Now, dialysis access could be, as you know, it could be an AV fistula, an AV graft. Dialysis can be done through tunnel lines or temporarily through peritoneal dialysis. But AV fistula, arteriovenous fistula, are most common types of dialysis of AV fistulas. And the commonest are the brachiocephalic at the elbow or the radiocephalic at the wrist. And the other forms of fistulas could be a BVT, or basilic vein transposition, in which the basilic vein is quite deep and it can't be used for access. So it's dissected and it's brought more superficially and then connected to the brachial artery to form a fistula. And then you have loop thigh grafts, so loop arm grafts, in which a prosthetic graft is used with connections to the artery and vein, and that prosthetic graft is in the form of a loop, can act as a fistula. Now, stenosis can happen. Usually, most common type in brachiocephalic or radiocephalic fistulas are in the ascending cephalic veins or at the anastomosis. Similarly, in BVT and in loop thigh grafts, the anastomotic, especially the venous anastomosis, they are the most common sites of getting stenosis. So we'll briefly go through a couple of cases just so that you can get an idea. Now, this patient came in with fistula not working. So what we've done is the top picture, you can't see any fistula filling, although we've put the sheath through the cephalic vein going down, and we've crossed the anastomosis and into the artery, and of course you inject from the artery and then it flows. It should flow ideally into the fistula as well as downwards to the hand, but as you can see in the top image, it's just flowing down to the hands and not into the fistula, which means that there's a tight stenosis there which is not letting it do it. So we did some angioplasties, a long angioplasty with 5mm balloon, and as you can see in the bottom picture, now the same run that we did before, now you can see blood flowing into the fistula. So that's how you treat it. And obviously you look at the ascending cephalic veins and central veins to make sure there's no stenosis, and then you have to treat them as well if there is. Another case, another brachiocephalic fistula in which we have punctured the cephalic vein, have gone around the anastomosis, done some images. You can see there's some filling of the vein, but it doesn't fill the rest of the vein. You can see a tight stenosis on the second image, which was angioplastied with very good results. Similar patients can come in with acute thrombosed fistulas, and what we do is we can either start them on lysis or give them a bit of TPA and open these fistulas up. And once the clot is dissolved with lysis, then we treat the underlying cause, which would either be a stenosis at the venous anastomosis or the arterial anastomosis, or both. Moving on, so we come across emergencies like GI bleeds. GI bleed could be upper GI bleed or a lower GI bleed. The upper GI bleed, usually they have endoscopies before. If it's bleeding from the stomach, it could be a left gastric artery. If the bleeding is from duodenal ulcers, it's usually the gastroduodenal arteries. So usually patients have 2 endoscopies before they're referred, 2 failed endoscopies before they're referred for embolization. Or sometimes if the bleeding is so much and the patient is unstable, then the endoscopist can't visualize the bleeding artery and can't treat, then we don't waste time. We bring them in and we embolize the bleeding artery. Lower GI bleed, you have to be very careful, because in upper GI bleeds, there's some evidence that if you can't see an active bleed, then you can still embolize the GDA to prevent future bleeding, but there's no such thing with a lower GI bleed. So if you don't see bleeding, active bleeding, the artery may be in spasm or the bleeding may have stopped when you're doing the procedure, you can't embolize because there is a very high risk of bowel infarction. So what I tend to do, if the patient is stable and we have time, I get a CT scan so I have an idea of where exactly they're bleeding from. Otherwise, if the patient is unstable, then you don't waste any time. You go straight ahead and do an angiogram, but you have to super selectively look at all different sites of the bowel to make sure you don't miss the bleeding. So one case is a 49-year-old female with male patient, background of Crohn's, was 5 days post-laparotomy, ileocolic resection and defunctioning ileostomy. Now had severe abdominal pain, was unstable, was fresh blood coming from stoma. So he had an urgent CT angiogram. And as you can see, sorry, my arrows are not working, but I don't know if you can see a blush in the bowel in the left corner there's a high density, that's contrast extravasation. Took the patient to the lab. You can see the catheter in the SMA. Now the catheter is in the main SMA. We did an angiogram and we couldn't see any bleed. So you have to be super selective, and that's the beauty of doing a CT scan, is it kind of makes things quicker for you. So you roughly knew which area was bleeding. So we went into the artery super selectively, and we found that there was a blush, as you can see here, contrast blush. Then this artery was super selectively catheterized. Make sure that we are in the correct artery. We go as close to it as we can, and you can see there's a small micro catheter coming out of the parent catheter that we use in order to get into tiny vessels. And we've used a very small coil to stop the bleeding, and as you can see, this is an angiogram from the same micro catheter, and there's no extravasation. And these procedures are pretty rewarding, because you can see that the patients start to become stable within, you know, a few minutes, it's usually good results if you found the bleeder and you've embolized it. Now, trauma is another, you know, emergencies, a trauma, injury to the arteries, to the blood supply in any part of the body. We can treat them. One of the examples, 20-year-old female, road traffic accident, was pretty unstable. CT showed multiple bony fractures. However, they had a thoracic aortic transection. So you can see on the inner border of the descending aorta, you can see a mushroom-like thing. That is a very dangerous aortic injury. The scan was done at 10:38 a.m. and the patient was in the lab with us at 11 o'clock. You can see the pigtail catheter. We've done an angiogram. In the first image, you can see on the inner border of the aorta, you can see that big lump. That is, you know, aorta getting ready to be ruptured. The second image shows the stent graft. We haven't deployed it, but as you can see, the deployment has to be very precise, because you need to make sure that you don't cover the left subclavian artery, because that will, obviously, it's a stent graft, it's a covered graft. If you put it across the origin of the left subclavian artery, that will block it. So your positioning has to be precise in order to cover the damage in the aorta, however, not to create any more problems. And that was beautifully placed. You can see all the three vessels of the arch are still running, and you can't see that mushroom anymore. So that's been beautifully treated, and another life saved. Now, these are just a few pictures of aortic aneurysm repair that we do with stent grafts. The first set of image, you can see an angiogram with an aortic aneurysm. The images below that are for the stent grafts that we use. That's how they look like in reality. And the image next to that is the image of the aorta after putting the stent graft in. The three images on the right are the fenestrated grafts with fenestrations for the celiac, SMA, and the two renal arteries. We do 2-vessel, 3-vessel, 4-vessel fenestrations, and they're custom made for the patient. So they're made after precise and accurate measurements of the patient taken from the patient's scan, and they're literally made for the patients. So highly technical procedures that we do in vascular radiology. So I think that was enough of the cases. Hopefully that helped you understand what vascular intervention is about. I hope this talk was helpful.
Thank you so much, Dr. Sayed, for that talk as well. We have a question from Dr. Flood, Karen. What is your favourite part of your job, and would you recommend IR as a career if you are female?
Right. So first part of the question, what is your favorite part of your job? I think Professor Ganji kind of answered that. I think you have to be very passionate about your job. Interventional radiology is challenging. work-wise. We come across very difficult procedures, and also balancing work with family life. If you're doing full-time on calls, you get called overnight. So you have to be very passionate, and if you really like what you're doing, that's kind of more than half of the battle won. Favorite part would be, obviously, I find interventional radiology is very rewarding. So whatever you do, like as you see in trauma patients, when you have GI bleeders, you treat it. The bleeding, you can see the bleeder, you block the artery, and the results are right in front of you. And I think that's my favorite part, and especially if you're doing something challenging and that goes really well, and you have so many success stories, and that's what keeps us going. Absolutely would recommend it to our female, all the female medics. There are different ways of doing that. I think for female, I think the most important thing is, could you have a personal family life as well as do a career which is as busy as I are? Yes, you can. It's difficult to maintain that balance, but it's not impossible. A lot of people go for family during the training years. Some people do it after they become consultants. I think what I do is I work 4 days a week full time, and I do full time on calls. You have to have supportive family and supportive work colleagues, which I'm blessed with. It's challenging, but it's doable, and absolutely would recommend it. You can go part-time, do 3 days a week, and I work 4 days a week. Monday is just dedicated to my 3-year-old, so we spend all day together, and weekends as well, so it works absolutely fine for us.
That's great. And got a next question, which is, how closely do you work with the vascular surgeons or with other specialties?
So radiology works with all specialties of the hospital. That's how we work, all parts of radiology. We work very closely with the vascular surgeons, so it's a vascular service that we provide, and we work very closely with the vascular surgeons weekly. Every Friday we meet on MDTs, but we meet them every day. Every day there's a meeting, we discuss patients. Before lockdown, we would go and do ward rounds with them. There's a rota, and obviously the patients and all the patient managements are discussed together in the MDTs or in meetings, and we do the scans together, and everything's just done together. So yes, we work very, very closely with them.
Great.
With the other specialties as well.
Yeah. Well, we've just got a final question from Keenan, which is, do you think vascular surgeons will come to take some current or future vascular IR work?
I think in a lot of places they have, but I think the main thing is they are working closely together. Yes, some of the endovascular procedures have been added to the vascular surgical curriculum, and we do train them even in our hospital as well, and wherever I've worked, they've always been there. And I think the key is to work together. They're not here to take over our job, or we can't take over theirs. So we have been working together, and I think maintaining a good friendly relationship with them is very, very important, and that's what we've done in our department as well, and it's working absolutely fine.
Okay, and just a quick question just to finish off then. Approximately how long do your procedures take?
It varies. We do a wide range of procedures. We do line insertions, PICC lines, tunneled lines for dialysis or for long-term access, and then on the other hand, we do a very complex aortic procedure, which involved thoracoabdominal stent, putting stent grafts in with all the fenestrations. So you have to put fenestrations in all the arteries coming off the aorta. So there are a variety of wide range of procedures. So the lines would probably take about 5 to 10 minutes, and the complex aortic procedures may take about 4 to 5 hours. So
great, thank you very much. Yeah,
no worries at all. Thank you very much.
Thank you, Saira. It was an amazing talk. Thank you.
Thank you very much. Thank you.
Thank you.